Hello, everyone. Thank you for being here. I'd like to introduce and have our panelists come up on stage. We have Dr. Salvatore Viscomi of Carna Health. Then Jean Magkilat, Health AI. Melody Weston, Embrace Global. Abraham Zerihan Magenta, Last Mile Health. And Dr. Shibu Vijayan of Cure.ai. So today we will be talking about how technology is rapidly transforming how global health professionals are trained, supported, and retained, all while breaking down critical barriers. We have an expert panel here who will shed light on really how this tech-enabled technology is helping professionals navigate what is such a rapidly and constantly evolving global health landscape. So Salvatore, let's start with you. Your platform not only screens for chronic diseases, but also upskills local providers. How do you see digital health tools filling training gaps where specialists are scarce?
First of all, thank you, Saudi Commission for Health, especially for the opportunity to speak here, and for Devix for organizing this wonderful event at this beautiful venue. We are a digital health platform for chronic diseases, which generally have been managed by specialists such as nephrologists, endocrinologists, cardiologists. The large majority of the world does not have the numbers of specialists to take care of the patients. The 1 billion patients, for example, that have chronic kidney disease, there's not nearly enough to manage those patients. So you need to use digital tools to help enable and empower primary care doctors, nurses, technologists to do the work of specialists, right? And then to utilize the specialists to help the primary care physicians manage their patients. And so our platform allows that to happen in a seamless way. And so we can capture data very easily. That's not the challenge. With point-of-care testing, you can collect blood and urine samples, identify who has disease, stage disease. The challenge is how do you get that patient to an outcome of a healthy outcome. And so testing is the first step, but not enough. And so this is where the AI and digital tools come, is to stage patients, identify risk progression, stratify that risk, and then get them the help they need. And in many cases, that's going to sit in primary care. And with our tools, the primary care can become a specialist for that patient with the AI tools that are enabling it.
Now, John, you slightly worked in a different field. You work at the intersection of policy, education, and technology. What are the biggest challenges you see in bringing regulators and policymakers to the table to get them to actively participate in AI initiatives in health?
At Health AI, we try our best to work with diverse countries from different income levels. So that being said, the challenges as well is diverse. But I would want to mention two common challenges that we usually face when we work with these countries. One is the red tape. I think when you work with governments, as much as possible, we want to expedite things, but there are rules, processes, and regulations that we need to respect, and that could delay the initiatives that we want to start. Second is competing priorities. Our CEO, Dr. Ricardo Baptista Leite, was telling me, John, how could I convince Minister of Health, to think about AI governance or regulating AI-enabled medical devices if in that country there are only 2 or 3 MRI scanners? So most of the time, especially in the low-income countries, there was like, maybe this is not our priority for now. But then we also take this as an opportunity for them to understand that AI is not the future. AI is the present, and they need to react as early as possible to avoid, this, how do you call that, this inequities, the potential of inequities through technological advancements.
Melody, turning over to you, you work in different settings. You work in equipping frontline providers in humanitarian and crisis settings. How can both low-tech and high-tech training solutions operate in these kind of emergency settings and become integrated into communities where crisis is endemic?
Thank you. So also just want to echo thank you to the Saudi Commission Health Specialties and DevEx for having us. We're very excited to be here. And I think what we look at Embrace is the first thing is the context and what's the least amount of technology needed. So we have a portable, low-powered infant incubator, and when we identified a need for thermal regulation for premature and low birth weight babies in these settings, we started out with an idea and co-creation with the end user. So our co-founders moved to India. They spent 5 years developing this device with community health workers, community midwives, frontline health workers in rural India to make sure that this high-tech, our device is high-tech, it does have a chip, a device would actually work in low resource settings where technology might not be as accessible. And because of that very intentional human-centric design that was right out of the gate, we were able to create something that not only works in crisis settings where perhaps our device only needs 30 minutes of heating and it draws the same amount of power as a light bulb, and then it stays warm for 4 to 6 hours, providing a safe space for that infant. And by working through that design process, we are now able to take that device into these settings, but as conflicts might shift or as countries rebuild, it's a sustainable solution while the country rebuilds its medical infrastructure.
And out of curiosity, what countries do you primarily work in?
So we're in over 25 countries around the world. We've now reached over 1 million babies since we were founded. Most recently this year, we've sent to Sudan, Yemen, DRC, Syria, sent to Gaza, Zambia. We just sent 60 to Cameroon to an amazing organization that has community midwives that work in and around the conflict areas. So all over, we really go where the need is.
All right, well, it's an impressive list. And Abraham, you primarily work in Ethiopia. Can you tell us what lessons about Ethiopia's experience could inform global approaches for upskilling community health workers using technology?
Yes, thank you very much. We work in Ethiopia mainly focusing on supporting the community health program. And around 4 years ago or so, the Minister of Health asked, can you help us digitize our training program? Because it's costing us a lot. We're spending around $600 per community health worker to train them on one module. And we're not even sure what the return on this investment is. So we got to work, and we felt like technology could cut down costs and also give us a better way to learn about how much change or difference are we making in our trainings. So we piloted this approach using a blended learning format and using a training app which has offline capability, which is really important for rural and remote countries. So what we found was that technology-based training was much cheaper. It was like 40% cheaper than the face-to-face training. Not only that, it was much better in terms of improvement of knowledge and skills of community health workers. I strongly believe training is a very important intervention. Oftentimes, it's doesn't sound very attractive. Sometimes our funders say, what is the evidence for training? We always try to provide as much evidence as possible, but in most countries in Africa, we have a huge skills deficit. It starts from our school system. School enrollments have increased, but quality has not kept pace with school enrollments. And then after school, when you are joining the workforce, the chance of closing that gap is not very high. So this investment in community health workers in Ethiopia, most of them are female, by the way, all 40,000 of them are female. And closing that skills deficit, particularly in women, in our female workforce, is even extra important because most of the time, most of the women labor force is not in the employed paid category. So there's no way to close that skills deficit. So I think investment in workforce development is investment in human capital, and I think this is a very good demonstration that we have done in Ethiopia.
I think you bring up such an important point, which is everybody assumes that training is expensive, but there is an ROI at the end of it. I mean, I'm just curious to delve into it a bit deeper. How were you able to make that case that the return on investment, how were you able to show that?
Yes, it's a very good question. Me as a public health professional, I don't even believe that training needs to be justified. It's, in the Western world, every physician, you are a physician, I'm sure you're supposed to go and undergo training every year. So it should be the same in Africa for community health workers. We need to train them every year. Protocols change, the way we do things change, and they need to refresh their knowledge and skills as well. I think what needs to be justified is how effective is the training, how cost effective is the training. So some of the things that we have employed is one, skills testing. Instead of, usually traditionally trainings are pre and post knowledge tests, and there isn't much that comes out of that. So, but we invested in government skills labs, and we measured the skills of community health workers before and after training. And we are also going beyond that and trying to measure now, are they applying that skill in their workplace? So I think there are ways to really quantify and measure it.
I think that's an interesting framing, that training shouldn't have to be justified. It is effective and has such results. Shibu, what are some of the challenges you've encountered bringing AI-powered tools to lower resource settings? And conversely, what are some of the successes that people may assume are not possible in these kinds of settings?
Yeah, so thanks for the question. So just wanted to give you an update about what we are doing. We are providing point-of-care X-ray AI reading, which enables outreach setting tuberculosis and lung health screening. And also we're providing AI co-pilot for frontline health workers, primarily focusing on the communities. So I'll structure the challenges as one is infrastructure challenges, like how do you power your X-ray systems. We don't provide hardware, but we provide software solutions. And still we need some hardware to actually function, the software need to function. Second thing is connectivity, internet availability, because then there is a cost attached to it. So that provoked us to innovate and then come up with solutions like which is offline setting working, in outreach setting. Third one is a regulatory thing. So many countries are not, so we are good in doing pilots and demonstrating successes, all these things. When it comes to scale, government has to change the policy. The system has to be in place with regards to AI, digital systems, storage, computing, and all these things. In low and middle income countries and in early stages of in preparing that regulatory framework. So that's something, a clear bottleneck to expand the services beyond. And digital, if you're not expanding, you're not reaping the benefit of it. Third thing is technology acquaintance or adoption, the trust issues, whether machine can do it or not. When we started actually in 2017, when we did the first deployment in Philippines, even health workers actually were not trusting, I've been doing this conventionally for I was to wait for 2 weeks to get a radiologist report to act on it. And suddenly this is happening. I can't believe it. So there has to be a learning curve. So the trust is actually a learning curve issue. It's an additional training. I've seen in Rwanda where they have digital adoption officers being positioned in health posts to make sure people are actually adopting technologies and kind of inculcating that behavior. So the success is that once you reach a tipping point and get convinced, and you take along the governments that there is a lot of co-creation. We cannot just dump technology into the system and say, hey, we are done, we are a technology provider, our job is done. we have to work with the respective governments. I'm just reiterating government is important. Partners are catalytic in that conversation. So you need to help the government to understand what framework they need to do, what regulatory mechanism, what skill set they need to bring in. And how do you fit the patient who are being, notified by an AI output into their care cascade pathway? So because we cannot have a standalone system. Okay, this is TB. I'm forgetting about all other findings, right? So what if technology is saying there is a probability of TB? I rule out it. Then what does that shadow looks like? How do I profile my patients? So these are all health system challenges they need to figure out. The best example, best success, I would say, Kenya is the best example, right? So the X-ray has been known, chest X-ray has been known for only notifying TB, and that's popularly adoption. But they also realize that these have capabilities of general reporting of X-rays because they have a dearth in radiologists in the country. And now they are defining lung health pathways. I mean, understanding how nodules, lung nodules need to be profiled, understanding how silicosis, pneumoconiosis need to be detected because the AI have capability of flagging the probabilities of all these things, COPD. And they are also bundling other AI-enabled technologies. I would say we don't look at AI as one thing. You also look at a system, ecosystem building. So if you are looking at primary healthcare automation, look at, okay, while I'm automating, what all technologies I can bring in, what all point of care technologies which have dependencies on specialists to interpret could be despecialized. For example, handheld AI-enabled spirometry devices is available now. So if your X-ray is saying TB is not there or some other shadow is there, can you functionally evaluate the lung functions? Can we characterize the cough of the patient? There are cough applications which say about your underlying lung disease. I think creating that care pathway is a way forward for countries. And best example for me to quote is the Kenyan example. They are looking at lung diseases, integrated lung diseases care pathway. There are quite a few other examples which I'll come back in subsequent comments. Thank you.
Yeah, no, definitely not looking at AI in a siloed fashion. It must be systemic to all of the healthcare to really produce the benefits. Salvatore, circling back to you, we were backstage talking about your travel agenda, and because you like to be on the ground when your projects are launched, so it's quite the busy schedule. So, building on that, what are some of the biggest lessons you've learned from rolling out tech-enabled training in such different contexts? Bermuda, Cameroon, soon the Philippines and Italy. What have you learned from that?
Yeah, just to provide the audience some guidance. So we're a digital health platform that integrates point-of-care testing, and one of our focus areas is chronic kidney disease. It's 1 billion people in the world that have this disease. 90% or more are unaware. So what ends up happening is that people end up crashing in dialysis. And the first time they see someone that can take care of them, it's a nephrologist monitoring their dialysis, which is expensive, unavailable, and it's not a high quality of life. So we've been fortunate to be in multiple diverse sort of landscapes for healthcare and lots of learning lessons, and we're learning every day still. I'll give you an example. In Bermuda, where we launched, Bermuda is an exception. They have plenty of specialists for their population, yet it's not without issues. So we did a national program. We identified disease in 51% of people that were deemed at risk, and we put them on a pathway to see a nephrologist. Fortunately, our platform tracks patients, and it was a critical learning lesson to make sure you track. Because what we found out is people were not going to their nephrologists, and then we figure out why not. So there were co-pays, for example. So understanding that could be an obstacle. The GPs were not referring because there was incentives not to, financial incentives not to. So if you're not on the ground and understanding and finding out why patients are not going to the next step, you'll miss out opportunities. We also found out that the ratio in female to male was 2 to 1. So high-risk males were not coming for free screenings. So we needed to be creative, right? So look for mobile units, go to sporting events, right? Go to places of where people work. These are what we're thinking about doing to And in Cameroon, we just launched the largest CKD program in the world. We've enrolled 30,000 people. We are in the process of doing that. We are over 50% done. We're about to do 75,000 subsequent to this. There, for example, the number of nephrologists for a country of 30 million is probably around 20. And so you cannot think about, I'm going to refer to a specialist immediately. So the learning lessons there is how do you engage the nephrologist to work with primary care. So that's what we're working on now. Getting the nephrologists are needed, but we don't need them seeing individual patients from our programs. We need them overseeing programs, right? Overseeing a community. And we also need, and the one thing I'll say, because we talk about all the technology, it's really important that at the end of the day, we're talking to patients, and no amount of technology will get them to an outcome unless there's a human being that they're talking to that is empathetic. And so all our programs, despite having cutting edge technology, at the end of the session, after blood and urine testing, all the AI is working, we're collecting data, they will speak to a human being that will talk to them about their condition, reassure them, and tell them the next steps. And we often don't forget about that. That's a learning lesson for us. There'll be new challenges. We're launching a program in the Philippines in a few weeks. We hope to launch other ones in the Dominican Republic, hopefully in many other parts of the world. The learning lessons is don't assume you know everything just because you had success in one part of the world. There are different challenges, different patient risks, different cultural differences, the language you use. And so we're still learning.
I mean, that's such a staggering figure from Cameroon, 30 million and 20 specialists for the whole country. So obviously just speaks to the importance of the work that you're doing. John, let's stick with the theme of lessons learned, and you particularly worked with Germany's health system, integrating international health workers. What lessons can we apply to preparing workers for AI-driven health systems globally in countries across the world?
When I was working in Germany, I was working with 15 different nationalities, helping them integrate in the German healthcare system. And modesty aside, as an integration officer, I think the integration program of our hospital, or my previous employer, worked well because there was one holistic strategy. When I say holistic strategy, communication strategy, the onboarding program, training program, support system, and also logistical support, right? Because these people were moving from one continent to another. So in terms of AI, it's also important that healthcare facilities must have their governance system, right? Not because AI is the new thing, then okay, let's have it without being strategic, without thinking what could be done prior to the application of the technology. So that being said, it's very important to establish to have a structured policies, right? Okay, AI will be there, but as a support, but not to replace the health workers, right? The accountability is another topic, right? Will it be the responsible of the health practitioner or that AI technology if something happens to the patients? So as well, because AI is something now, well, as mentioned a while ago, it's here. It's transforming the healthcare system. And AI is rapidly evolving. So training programs must be continuous as well, right? Because you cannot just say, okay, we're done with the onboarding process and that's it. No, because maybe 6 months later, there's something new that the health workers need to learn to avoid, risks.
I think it's such an important point that you raised, that it's not about replacing health workers. And like you said, Salvatore, it's the human touch at the end of the day. A somewhat related question, Melody. What role does technology play, not only in training, but in sustaining and supporting workers who face burnout in such challenging circumstances?
Yeah, there's sorry, I've been thinking about everything I've heard. I'm like, oh yes, that and that. But when you're thinking about healthcare workers, I mean, I could just go back to like, why are they doing this? Why did they choose this profession? And for many of us, it's a calling. And healthcare workers find joy in providing care. So where are administrative tasks becoming other logistics that they have to deal with becoming a burden? And I think that my peers on stage here with me have some really innovative solutions to help relieve some of that burden. So that way that our frontline health workers can actually focus on the care. And some of the things that John was saying and that Abraham was saying about trainings too, continued training. Healthcare workers want to provide care. That continues to change. Even in our work, when we work with a partner, we donate our device, but we are in it for the long haul and providing continued training on skin to skin, neonatal hypothermia, to make sure that we can continue to address the questions that arise and making sure our partners have the skills that they need. And if we can't provide it, then I think that leads into my next point as far as really radical collaboration between other organizations. You know, if a partner has to provide 3 different reports on their care, on what they've been doing to 3 different partners, where can the organizations who are supposed to be helping build capacity and support our frontline workers work together to minimize that burden for them? Where can we collaborate to make sure that we are sharing the appropriate data to make sure that our partners aren't having to report things 3 different times in 3 different ways? And then lastly, I just think there's like so many simple ways for technology, WhatsApp, Slack, very low tech ways to build communities of care. We're human beings. We need identification. We need human to human contact. And especially in the places where Embrace works, there's a lot of healing that needs to happen, not just physically, but emotionally. And technology links us in a way that our grandparents never even could have imagined. And so where can we use that to connect our frontline health workers, to connect them to each other, to different resources? And there's so many, AI agents are fantastic and going to help be able to move our work forward at such an incredible pace, but at the end of the day, we need that human-to-human contact. We work with incubators, but at the end of the day, moms and babies still need that skin-to-skin contact. We can't ever replace that. We need to always just make room for other solutions to help build and move our impact forward.
And certainly it needs to be a continual learning process because a technology like AI is changing every second of every day.
I can't keep up with it. I'm just like, I'm going to head over to Salesforce after.
Well, I'm glad you made the point as well about the fact that it's also more basic technologies that we overlook, like WhatsApp is integral and has been revolutionary in a lot of settings.
And we're still all using it. So AI is going to have a place, but it doesn't mean we're not replacing, we're just adding more things to our toolbox. And not every tool is right for every situation. So if we're providing continued training, we have the education, then we just want to make sure that our frontline health workers are empowered to make the right choice for the right situation, and that they have all the tools necessary in front of them, and that the community health worker in Ethiopia, the nurse or community midwife with an Embrace incubator in Cameroon, or in one of your doctors in Cameroon, our doctors over at CHOP in Philadelphia, I know there's someone here from CHOP in Philadelphia, they all have the same access, and that we've all addressed that equity issue as well. Because I haven't heard that come up yet. So I think that's also a key point.
Excellent point. And speaking of community level health workers, Abraham, you've worked with quite a bit in your experience. What have been the key enablers and barriers to scaling tech-enabled training at the community level?
Thank you. I think when we started it, there was a lot of skepticism. Can this work at the community level? And I feel like it has actually we have actually delayed introducing technology at the community level because of this skepticism. I think COVID somewhat helped us to really fast track technology because it forced us to start utilizing technology. I think we could learn some lessons from, because social media has infiltrated even at the community level. You see our community health workers using Facebook, TikTok, WhatsApp, Telegram, all this social media, without anybody, providing a TOT on how to use them doing workshop. So I think one of the barriers is to make it user-friendly, to make it intuitive. And I think that's what we have demonstrated. To give you one example, we were being challenged when we introduced these digital devices and saying the older community health workers will not be able to keep up, whereas the younger ones would use it easily. So one of the things we measured is their knowledge and skill acquisition based on their number of years of experience. And surprisingly, the older, more experienced community health workers did better than the younger, less experienced community health workers who are supposed to be more tech savvy. So if you are able to make those tools user-friendly, intuitive, easily navigable, then I think knowledge and skill acquisition using technology becomes much more easier. And the other, I think, the biggest justification that governments are looking for is cost. If you can show them that by introducing technology without compromising quality, actually with better quality, you can save this amount of money, especially now, that argument is more relevant more than ever. So if you can show it costs less, it's more effective, and also make sure that you make it more user-friendly. I think those are the most important factors. I think infrastructure-wise, in rural communities in most of Africa, including Ethiopia, internet availability is still not very reliable. So you have to be able to introduce technologies which can withstand those sort of challenges. That's why we work so hard to introduce something which has offline capabilities. I think these are some of the factors for addressing the barriers.
Yeah, and certainly the issue of cost and melody, what you're talking about, partnerships and cutting inefficiencies, it's so important in this new era that we're entering of traditional foreign assistance in retrenchment. So everyone has to kind of rethink their models and rethink how they're going to be moving forward. I want to return to this theme of lessons that can be applied elsewhere, because Shivu, Cure AI has worked across more than 100 countries, which is very impressive. What lessons have you learned about adopting AI-enabled training in such vastly diverse contexts?
Yeah, so as I mentioned, though we are present in 100+ countries, the penetration at scale, I would say limited to around 10 countries. Because reasonable scale to have the number of X-rays being processed. So I'll just give you an example. 3 billion X-rays, chest X-rays happen globally. That's an estimate. In my country itself, in India, there are 120 million X-rays happens. It's a very tiny proportion of it is actually being read and acted on. So if you look at the TB problem globally, there is 10 million every year, and there is a gap of around 400,000 detection as per the estimate. So what we are now advocating, the lessons learned, is that typically the TB program has been designed, globally the guidelines are designed when tiny X-rays came into picture, that become portable. Okay, so the device become mobile, and you can go to the community and screen. And there comes the value of AI, who is going to read the X-ray and interpret. So the AI was an augmentation to the technological advancements happen. But on the other side, who is reading your facility level X-rays? So the discussion around facilities was, so we have ample skill set available in the facilities, they will read it. But apparently they were not doing it, because it's mostly X-rays, a test ordering doctors, investigation. So they order it, they have a look at it, and then they make a clinical judgment and then move on. So we started actually kind of thinking about what are different ways of using AI. So we started putting that AI in facilities where high footfalls are there. So X-rays has been taken for multiple reasons, not only for one disease, but for like wellness checkup, pre-anesthetic checkup, injury, trauma, multiple other things. So when the AI ran at the back end to screen all the X-ray, regardless of the reason it is ordered for, surprisingly, we found 30% increase in picking up TB presumptive cases. So your overall funnel of people eligible for getting tested for TB increased with a high precision. And the outcome of that is 20%. And we also did a cost-effective analysis on that. And if you follow in a facility-based AI-enabled pathway of care, you save $100 versus a radiologist pathway. And because you also detect early, you detect asymptomatic TB cases, and there is also an advantage when the junior doctors then started seeing an AI output with demarcation of abnormalities, they started upskilling. Okay, they have an assistant to verify their diagnosis, their mental diagnosis to, okay, fine. Now it's been reassured, fine. That is one thing. Second thing, okay, you have one disease you ruled out. How do you, this is an example from Nigeria. How do you create, what are the other abnormalities? They started a teleradiology referrals for rereading of abnormal X-rays by AI. And there is a whole bunch of clinically diagnosed TB emerged from this, and other disease also. First example in Nigeria, so people noticed that enlarged cardiac shadows, and they found people are kind of puffy people are coming, and they realized that's the first occasion to be tested for hypertension, because there is an enlarged cardio, they need to refer. So I think it's evolving. We are also learning, because what all things actually, the technology is actually unveiling, and then how we create care paths. The biggest learning is that what are the different use cases? How do you kind of multiplex the existing AI solutions to create multiple care pathways?
Now, I'd like to ask everyone on the panel kind of a broader, overarching question. But before I forget, we will be saving time for a Q&A. So if you want to think of some questions, we'll try to get to as many as we possibly can. But before we do that, as we all know, technology risks widening digital divides, which are already, very huge around the world. How can we ensure that tech-enabled training reduces inequities rather than deepening them? Salvatore, let's start with you.
Well, I think the technology allows us to scale very quickly and get results, and it doesn't necessarily mean we're going to get the patient the outcome they need. So we need to always reflect on how do we make sure that all the data that we get is utilized in a way to make sure that no matter where in the world you're living, you get the best outcome. And to give you an example, in our world, for example, if we do a large-scale national screening program, we're going to find, in a country of 100 million, we would find about 20 million people with disease. Where the AI is helpful is understanding risk of progression. How do we understand like all the ones that are stage 2, which is a staging classification, which doesn't get treated right, in most places. But how do you know all the people, the millions that are stage 2, how do you identify who are the most at risk so you can dedicate the resources towards them? So that's where the technology is helpful. But you need to have a monitoring system to make sure that patients are engaged along the way. Because if you can have all the data in the world, all the AI, if the patient's not engaged, all the way to the end, and that means they need support themselves. Are there transportation issues? Are there fear issues around certain types of testing? Are the medications available, right? So there are so many challenges beyond just the AI and testing, but the AI can definitely help stratify the risk, get at least triage patients. But the challenges are, there are many steps beyond that. Some that can be solved with AI, some that really require champions, whether it's a president, a minister of health, whether it's a private company, whether it's a foundation, that support will be needed.
John, what are your thoughts on the digital divide?
Well, I would like to talk about accessibility. Internet now allows us to learn content from, let's say, the US, while I am on an island in the Philippines, right? But then, not every country or not every island has also stable internet connection, and that already, divides, or that can create division. So what I've been learning as well in this event is that collaboration and investment on infrastructures. You know, let's start first maybe investing on the basic things before embracing the bigger ones, because it will. Let's acknowledge it. AI will divide or will widen the division if the small things will be kept ignored.
One step at a time. Melody?
So I will go back to, I mean, I'll die on this hill, but co-creation. And I'll say it till I'm blue in the face, but really we can't develop tech without the end users being involved from the gate, right from the start, right out of the gate. And I will say, just speaking from our experience at Embrace, we did it really well at first. For 5 years, we developed this innovative technology that works in some of the world's most challenging settings, and it went to market. And then the people who it was meant to who it was designed for were not included in how it was going to be distributed. And Embrace actually went and became a for-profit model, and it failed as a for-profit model because there wasn't that co-creation. It went from, this is something that we're creating for the communities, to a top-down deployment strategy, and you didn't have that community buy-in going into new markets. And so how did you expect to be able to scale if you don't have the buy-in from the people who actually are going to be using the technology? And so now we've switched to a nonprofit just a few years ago at the end of 2021. And we're really working with local partners and going from a ground-up approach to make sure that we're getting that buy-in right from the beginning, from the time we go into a new region. And it's key because there's two silos there. There's the tech side and then the end user side, the community side. And from the tech side, they have to understand, they have to understand what the issues are and the actual issues on the ground. And the end user side has to understand tech's capacities. I don't even understand all of AI's capabilities today. And if I get it today, a week from now, I'm not gonna, it's changing so fast. So just because you start with co-creation doesn't mean that you get to a certain point and you can just let it go. I think it needs to be a consistent principle, leading with empathy, really thinking about the humans at the end of it. So we do keep that humanity, I said before, the identification, that human-to-human connection. It has to be in all we do, especially in this space.
Of course, you have to have buy-in from the people at the end of the day that you're treating. Abraham, some of your thoughts?
Yeah. I believe technology is one of the most important equalizers of our time. Access to information, thanks to the internet, a person in New York or in London, can have the same information, or a person in rural Africa or Asia can have the same information as the person in these Western capitals. So I think technology is a very important equalizer, but I think what we should not forget is that access is not the same across the gender divide, across the income divide. If I give you one example, one of the first things we have done when the COVID pandemic hit was come up with an app, a training app called COVID-19 Ethiopia. And it was put on the Play Store, it was available for everybody, and surprisingly it took off, because at that time, we could not have face-to-face training, social distancing, face trainings were banned. So more than 20,000 learners downloaded it in the first 1 month of its launch, which was really, really encouraging for us. But then, so this is like, a very good demonstration of equalizing, people having access to information. But when we looked at the data, out of the 20,000 health workers or learners who downloaded it, only 15% were women. So technology can only equalize if there is access. So I think we need to always remember that technology is important, but without access, it will not achieve the intended goals. Thank you.
And Shibu, what are some of your thoughts?
Yeah, so I think from a standpoint of our experience, the technological divide is a reality. And again, as I mentioned, so then how do you kind of deploy it? So there has to be innovation. So what we did was like we made the first offline solution, like because we understood this is not going to function in the outreach setting in many of the countries where we work. So then that comes with a cost. Who's going to cover the cost of it? Because we compress all the algorithm into a box, a small tiny box. So there is an additional cost of it. But fortunately, it got listed in the GDF, and they approved it as a product, which is necessary to function. Of late, Starlinks is coming. So now we are started actually experimenting with Starlinks to actually kind of to fill that gap. Like how do you make sure? It also that the early days we are testing that in how it is working. So we also realize that there will be investment beyond the device, because there has to be some sort of rooftop construction, civil construction needed in many of the facilities if we would want to make it function. So I don't see that health AI as a siloed part. It has to be part of the digital public infrastructure. So so we need to kind of ride into that bandwagon and say, hey, your digitization agenda of any country, digital transformation, need to think about your health facility. The fintech has been a priority because many countries, banking automation, making sure that people get access to the digital money and all these things. But we are not thinking in the same line digital health is being delivered to the last mile. So I think probably using that fintech example and then kind of help countries to digitally transform their health system in the same way when we think about access also, because you mentioned about access thing. Yeah.
I want to make sure we save some time for questions. Does anyone, if you could just briefly introduce yourself and dive into your questions? We have somebody who will be walking around with the microphone. Does anyone have any questions for our panelists?
Hi, thank you. My name is Leah. Thank you to all the panelists and to the moderator for great questions for the panelists. I'm wondering how you're thinking about integration. So it's very inspiring to hear about all these tools that are being created. Some are being implemented, some are piloting. And I think we've seen in certain markets the problematic nature of not thinking about integration of these tools together within existing systems. By not thinking about that now, we could create problems for ourselves down the line and perhaps create inefficiency where we mean to create efficiency. So I'm just wondering how you're thinking about that. Thank you.
Thank you. It's an excellent question. So integration, does anyone want to pick that up?
Yeah,
Yes,
I can
Abraham.
respond to that. It's a very good question with a somewhat a complicated answer. For example, when we were introducing the blended learning app, we were introducing it on the device already procured by the Ministry of Health for electronic community health information system. We didn't want to have one device for this purpose, another device for this purpose, and community health workers are, walking around with 2, 3 tablets or devices. So that sort of integration, we were very conscious of. I think one thing which maybe is a challenge is we also don't want to limit different innovations to make sure that everything is integrated, because there's so many players, there's so many ideas. So there needs to be a balance where we have to make it somewhat integrated and cost effective without limiting new ideas, new entrants into the market, because sometimes just to maintain integration, you might end up sustaining or maintaining a tool or a technology which might become obsolete. And the pace of technology, I think, forces you to be open to new ideas, new devices, new innovations. So I think it's a balance of maintaining efficiency, but at the same time allowing new innovations to enter into the market.
Interesting. Does anyone else have any thoughts on that?
I mean, I would say it depends on where you are in the world. I mean, there are places that we will look to integrate immediately because it makes the most sense and the entire ecosystem is connected, but there are parts of the world that don't have that infrastructure. So the digital platform becomes things that future other products would integrate with. So yeah, I think integration is important when available, but it's not always available or the right move. And it's also where do the people that where do they get their information, or what do they have access to? And they might not have access to a portal like a lot of people in the United States do, but they have access to SMS, for example, WhatsApp, email sometimes, smartphones fortunately are everywhere. And so to me that's a priority in most places of the world, rather than integrating to an EHR that frankly don't exist in many places, or they're very fragmented. So even if you were to connect to one, you would connect to so many different ones. Yeah.
Right. Good answer. Does anyone else have a question? Sorry, I got the light, so I can't quite see. Okay. All right, well, I have a question because... Oh, there is? Okay, good. Sorry, I'm having a tough time seeing.
Thank you. No, I understand. I just wanted to ask a question about where higher education institutions fit with the kind of innovation and the sort of the sort of platforms that you're talking about, because that's the start, if you like, of a health worker's education, and how your kind of programs kind of connect with existing higher education.
The answers on the education front?
Yeah, I can also respond to that. We are providing this. So first of all, the trainings or the skill buildings should not stop when health workers leave these higher education institutions. That's a point we always emphasize, that education and upskilling is a continuous process. But there's also, lack of integration sometimes between the pre-service training which happens in these education institutions and also the on-the-job training for health workers. What we have tried to do is to integrate the two. When we do this blended technology-based trainings, we are doing them in this pre-service training institutions or education institutions, so that some of the lessons and the tools can also be applied pre-service in the previous service education. I think one challenge we have is that those two sectors sometimes are very different, where academic institutions are under the Ministry of Education. They have a different way of functioning, whereas once health workers join the workforce, it's a completely different system and government structure which leads them. So I think having the two sectors talk to each other and integrate and learn lessons from each other is very important.
Does anyone else have any thoughts? John?
When I was still working in Germany, what the hospitals do is to collaborate with higher education institutions. And that's where exchange of ideas and experience also takes place. And based on that, the trainings will be developed, right? By providing concrete examples that happened, for example, with a particular health worker from the Philippines working in Germany, or from India or Egypt working in Germany. And then we use those information to develop new trainings that will be implemented for the health workers.
And we do have a question in the front here.
Thank you so much. My name is Yoba Seidu. I'm a public health physician, and I work for the Clinton Health Access Initiative, and I'm the country director for Cameroon. So I thank you so much to all the panelists for your excellent argument and insights with regards to what can be done at macro and micro level to build the workforce. So my thinking, at least based on what I have heard, I think what I actually see is a solution that addresses the tip of the iceberg, right? But really, we need to go down, look at the broader picture. And the reason why I say so, I think Salvatore gave the example of Cameroon having just 20 nephrologists. And if we look at other conditions like diabetes, diabetologists or cardiologists, and so it's almost the same. right? And one of the things that we see is a lot of inefficiencies and missed opportunities. And these sort of inefficiencies are kind of defined by global bodies, like the International Society for Nephrologists, International Society for Cardiologists, and whatsoever, those international bodies. And those policies that those bodies kind of create, they are verticalized. So to one extent, you see maybe across sub-Saharan Africa, you see a patient who has hypertension going to going to solicit care for diabetes in the diabetes clinic. And there, he's not screened for his kidneys are not screened, his other conditions are not screened, and the like. And the same thing for hypertension, the same thing for nephrology and the like. So we can bring all of these innovations, but we need to think about how well to influence or in short to engage those global leaders, those global societies that actually formulate these recommendations and that pass this on to national societies and who also translate this into national policies. So if we don't do that, then we'll just continue having systems that work in silos, have tools and innovations that cannot reach the broader populations and that cannot actually meet the need of the public health need of the country. So I think as we are continuing this debate, let us also understand that those people, the international societies, the national societies, they are important stakeholders that need to be brought to the table, and we really need to figure out a pathway for integration and make a pathway for integration and making use of the minimal resources that we have in a more efficient way.
Well, thank you. Yeah, I don't know if anyone has any reaction. I think you made a very important point, which is, the silos, and how do we overcome those silos with international societies, national societies, and so forth. Does anyone have any thoughts on that?
So we do engage with professional bodies when we go to the country, because that also helps in creating local guidances what AI could do and how it actually kind of redesign the care pathway and also get the adoption faster. So for in our case it was largely pulmonologists and radiologists, because we work with the Professional Radiology Association or Pulmonology Association, and they are all actually part of the expert committee advising to the government. So that's one way to approach it. So wonderful thoughts. Thank you.
Yeah, thank you, Dr. Yalba. That's very insightful, and it's our reality as well. So we're a platform that does hypertension screening, CKD. We're planning to do diabetes and cardiovascular disease as well. So that makes it more of a uniform, a broader platform, which is important because a lot of the same patients have multiple risks. I think the answer also lies in the primary care system. Primary care is where needs to be empowered. They see all the patients generally, and so having the specialists empower, educate, be involved in managing the patients through primary care. That's the common denominator, is primary care at the front lines. And it's a challenging problem everywhere, including in the United States, where I practiced for many years, of what specialists, you go see a specialist for heart disease, they don't worry about your kidneys, they don't worry about your diabetes, and something gets lost along the way, right? And that's why we see such high readmissions rate and failures of prevention in the United States, right? Very high. But very insightful. That's why we're focused on primary care and utilizing the specialists to support rather than using the specialists as the front lines.
I think that's an excellent point that you make, that these are not just issues in lower resource settings in the United States. That could be a whole separate panel. Does anyone else have any questions? Yes, in the back. Mm-hmm. I think there's two. So there's the woman in the back, and then we'll get to your question.
Thank you so much for this discussion. My name is Miriam. I'm originally from Chad, though I was trained and currently practice nursing here in the United States. I'm also a founder of a Better Life Youth Association. It's a youth-led NGO, works in Chad it's focused on reducing malaria rates, addressing malnutrition, and improve access to maternal health. Having witnessed health system both in Western countries and low resource contexts, we see the gaps of healthcare firsthand, especially back in most African countries. So my question is that how can tech-enabled training be scaled equitably to ensure that the healthcare workers in low-resource countries, especially in rural areas, are not left behind in building the future of health workforce? Thank you.
I think this gets to kind of the digital divide that we were talking about, especially I think adding that dimension of rural workers is so important. Does anyone have a few thoughts on that, additional thoughts?
I was going to say, Abram has a really great solution that they've implemented with your app in Ethiopia.
Yes, I think, like you said, access to technology in these rural and remote areas is still a challenge. So we have to design solutions with that in mind. We have to design solutions with more resilient technology, hardware and software. There was a time where I remember we introduced solar chargers so that rural community health workers could charge their devices. So solving for unstable or lack of electricity in rural areas. I have mentioned investing in technology which has offline capability so that it's not dependent on internet. And also making sure that we provide the access to these technologies. So I think if we have that sort of thinking and put the people we are designing the solutions for at the center, I think we will address the problem. We did a human-centered design exercise when we designed this blended learning for intervention for community health workers, and that really gave us a lot of insight of what do they really want, what do they find acceptable. So I think when we design these interventions in rural and remote communities and community health workers, they have to be at the center of the process, and we have to make sure that they participate in the process, they participate in the content development, they participate in the technology, and also curating the whole program design and delivery.
And we are out of time, but I
really
do know
quick?
I promised this gentleman a quick question. So if you do have one, are you good? No? Very, very briefly.
Yes, thank you. My name is Joshua Trust. I'm way from Vienna, Austria. I'm a professor. I just like to thank you for the answers you give to all the people who ask you questions. But I just like more precisions. I'd like to know how can tech training maintain human interests?
How can it maintain human interest?
Okay.
Thank you.
Because it is with the way I see change every day, how we are progressing, I'm afraid.
Yeah.
Thank you.
So
Thank
let
you.
me give you one precise example for that answer. Comparing if this is done without technology and with technology, what's the difference? Usually when we train community health workers, we put them together in some hotel. We have a 100-page or 50-page training manual. We take them through slides and a very didactic approach to the training. So what happens is that they carry the training manuals to their health posts or community level, and then they do not have time to review if they forget how to do a specific procedure. For example, community health worker is supposed to do testing for pregnancy. Let's say 2 months after the training, she cannot remember. Maybe she has misplaced the training manual, or going through the training manual process takes a long time. If you take technology-based training, she has her tablet on her hand. There are, that technology allows you to integrate multimedia content. especially the women in rural remote areas, they have household responsibilities. Sometimes we have seen that they watch these training videos while taking care of their kids or doing household chores. So technology brings that efficiency and makes it easy for you to retain knowledge. That's one. The second is we're always improving treatment guidelines. We're always improving training protocols. When we have a technology-based training, we're able to push new content to the hands of the health access worker without reprinting manuals, without calling them to centrally for trainings. So technology gives better tools for retention of knowledge and skills, but also to stay up to date with new content.
Yeah.
This may not seem feasible in a rural context unless you go and see it and see how community health workers really are satisfied with a technology-based training because it makes their lives very easy. Let me tell you another very practical example.
Very briefly, not to cut you off. The speakers, panelists, hopefully you can stay around for some more interaction with our audience. I didn't mean to cut you off, but I know this has been really enlightening hour for me. And please join me in thanking all of our panelists for this discussion.